السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. I am Mosab Shetiwy, lecturer of surgical oncology, Oncology Center at Mansoura University. I'm the chief tutor of oncology this semester 13, for the year 2021. In this lecture, this is the starting lecture of the oncology module. We'll be reviewing the syllabus of the upcoming weeks. So welcome everybody. This module, this year actually, is your final year. Separates you from graduation. Inshallah, you reach this point with best of luck. You'll have to work hard through this module and the next two modules in the final year. Actually, the oncology module is a little bit complex. It contains many topics related to cancer in the adult population, pediatric population, and some disease-specific sites like urology and gynecology. To start with, in fact, oncology is a complex specialty. The subspecialties for oncology, including surgery, surgical oncology, medical oncology, and radiation oncology, all together form a circle or a network for treating cancer patients. Actually, surgical resection is the cornerstone of treatment of major solid cancers, and surgery has been the oldest form of effective treatment of cancers until recently. Chemotherapies and radiotherapies showed major advances. These advances demanded that surgeons work with other specialties and other disciplines to achieve the optimum results for cancer patients. Diagnosis and treatment of cancer has rapidly evolved over the past quarter of a century, with advances in screening, surveillance, diagnostics, and even effective systemic therapies and accuracy of radiation therapies. In addition to those in surgical oncology, for those whose cancer remain incurable, these advances significantly contribute to prolonged quality of life that can now be frequently measured in years rather than in months, as was previously measured. Lastly, morbidity and mortality risks of these treatments have markedly improved, in particular those associated with the more complex cancer surgeries. The advances in cancer surgery over the last 25 years, like the introduction in minimal access surgery, enhanced recovery protocols, anesthesia, and even intensive care units and pathways associated with better use of perioperative therapies, systemic and radiation therapies, all of these have led to ever improving outcomes in terms of both disease-free and overall survival. Furthermore, other medical disciplines applied to surgery, such as interventional radiology and nuclear medicine, now allows us to effectively treat patients previously thought beyond the scope of standard care. These advances are encapsulated in the application of multidisciplinarity, the principle that all disciplines are now essential in management of patients suffering from cancer. Multidisciplinary team working is now the standard of care in most countries and the legal issue requirement in many. So multidisciplinary team working is a prerequisite for optimal decision making in high quality retreatment diagnostics. Radiologists and pathologists have important roles to provide relevant diagnostic information. The surgeon must understand the strengths of other treatment options, and radiation and medical oncologists must know the strength and weakness of surgical procedures. Only then can a multidisciplinary team deliver quality decisions to benefit those patients. As the treatment and care of cancer patients becomes more complex, the optimal management requires the expertise of specialists from different disciplines. including but not limited to surgery, radiation therapy, medical oncology, and cancer nursing, in addition to pathology and imaging. This has inevitably led to the development of both a multidisciplinary approach and teams. So all the disciplines in the team are working together um, to provide the patient with the optimum chances or optimum plan for his cancer or her cancer. The advantages of such an MDT environment includes management consistencies, coordination and communication, educational opportunities, and potentially improved outcomes. Cancer treatment given through an MDT is logical and has become standard of care in many leading cancer centers in the world. Studies suggested that there is an outcome and survival advantage across various settings of different cancer subspecialties, ranging from primary surgery to palliative treatment for advanced stage 4 cancers. Let's take an example of breast cancer, where MDT has become imperative, especially for primary early stage treatments and those who have breast cancer at a young age. Since the time when Halsted procedure involving the removal of the entire breast, axillary nodes, and pectoral muscles was considered the standard and the only treatment modality for breast cancer, major advances have been made. First, it was shown that the addition of radiation therapy to lumpectomy was as effective as mastectomy and far less disfiguring. Later, the introduction of sentinel lymph node biopsy procedure that can allow us to spare patients with those patients without nodal involvement, spare them from axillary lymph node dissection. Recently, it has ever been shown that patients with positive sentinel nodes in some situations can be spared formal axillary lymph node dissection as long as they receive radiation, because radiotherapy to the axilla is the definitive treatment of positive axilla, not surgery. Radiation itself has evolved over time, while post-mastectomy radiotherapy are still a matter of controversy. Given the emergence of new radiotherapy techniques, current efforts focus on minimizing radiotherapy because of its worse or bad side effects. New techniques such as the IMRT, intense modulation radiotherapy, PBI, partial breast irradiation, and intraoperative radiotherapy or brachytherapy have become available. However, it's crucial to select the right patients for the right techniques. Systemic treatment decisions for breast cancer are clearly influenced by data gathered from pathology, radiology, and surgical procedures. That's why MDT is very important to provide these data, because the various treatment modalities are now influenced by each other in treatment strategies for breast cancer. It's undisputed that all personnel involved in the care of one specific individual should discuss and treat the person in an MDT setting. After discussions during these meetings, the treating physician can go back to the patient with more solid options to discuss, leading to more confidence in the patient-doctor relationship. And interestingly, in a recent survey, 63% of investigators from Western Europe declared that MDT was a mandatory part of breast cancer care in the country. Similar conclusions are likely to be reached for the treatment and care of all other cancer types. Lastly, the MDT is likely to expand in the following years, given the gradual implementation in the clinic of powerful diagnostic technologies such as next-generation sequencing designed to move from precision medicine to personalized or individualized medicine. These technologies will call for additional experts such as geneticists, bioinformaticians to enrich the MDTs. And you should also know that, or you should remember that the human being residing within the patient will need to be remembered in all treatment decisions. Breast cancer is actually one of the big four cancers worldwide. along with lung cancer, colorectal cancer, and prostate cancer, as according to statistics I'll see in a minute. In Egypt, liver, you should know that liver cancer or hepatocellular carcinoma is the commonest. It's out of the big four actually, but it's the commonest in Egypt. Worldwide, according to the Global Cancer Observatory, the International Agency for Research on Cancer in France, is always updating the site and the observations on cancer. And as you can see in the diagram, the pie chart, the big four are there. The commonest worldwide will be the lung, breast, colorectal cancer, and then the prostate. In Egypt, liver cancer or hepatocellular carcinoma is the commonest, followed by breast and non-Hodgkin lymphoma and bladder. That's according to statistics in 2018. These are the most recent statistics. In Malaysia, for instance, the distribution is a little bit reordered. Breast cancer is the commonest, followed by colorectal, lung, nasopharynx. In the Western Asian region, that involves the Gulf, Iran, Iraq, Jordan, Lebanon, and Turkey. This is the Western Asian region. The incidence of cancers is almost like that in the world. The big four are there: the breast cancer, lung cancer, colorectal cancer, and prostate cancer. We'll be covering those big four along with other cancers, but you'll have to stress on these big four during your course, because these are the most prevalent cancers worldwide and in most of the regions that you come from. So let's get to this syllabus. So oncology semester is an 11-week semester. It includes 6 weeks general oncology and adult oncology, 2 weeks for pediatric oncology and hematology, 1 week of uro-oncology, and 2 weeks of gynecology. This is a view of the timetable for the weeks to come ahead. All the lectures are going to be online lectures, and so are the seminars, except for the how to examine. We'll be getting to that. So lectures starts on Sunday till Thursday. By the end of the week, you should have downloaded and listened to those online lectures. Your clinical training previously was during the 5 days where you attend clinical training in oncology center, radiotherapy center every day, but due to the current conditions of COVID-19, the attendance will be only for 2 days. So you'll be required to, for clinical training, to come to either centers for 2 days. Half of you will be attending, for example, on Sunday and Tuesday, and the other half will be on Monday and Wednesday, and you'll be distributed into groups with our colleagues as your supervisors. By the end of the week, on Thursdays, every Thursday, you'll be having a how to examine lecture. This is a live lecture where you will meet with a colleague of mine, a surgical oncologist. He will discuss with you clinically how to examine a certain situation, like in the first week, lumps and bumps, second will be breast, third will be abdomen, and so on. And that will be requiring your attendance from 10:30 to 12 o'clock in the afternoon. And every Thursday at 12:30 for 11 weeks, you'll be having a themed case discussion, which has replaced the PBL theme previously used before COVID-19. The Thursday meeting or discussion, the themed case discussion, will be 1.5 hours long, from 12:30 to 2 o'clock p.m., where you will have an interactive session about the week's theme, and a step-by-step approach to the management of case through a case scenario. So you should come prepared on this Thursday to discuss the case for each week, inshallah. So let's start with 6 weeks of general oncology. Week 1 is about basics of oncology. You'll learn cancer epidemiology and screening. You will get a grasp on approach to diagnosis of cancer through some investigations and techniques. Here you'll be taught how to diagnose a cancer, and let me put it to you in short. To diagnose a cancer, you should have 3 tools for diagnosis, actual diagnosis, tools for metastatic workup, and tools for defining resectability. You'll be also taught how or given introduction to chemotherapy, biological therapy, and immunotherapy, and you'll be learning principles of radiotherapy. Those were the online lectures. Clinical seminars in week 1 involve one disease site-specific tumor, which is soft tissue sarcoma. The other clinical seminars involves nutrition in cancer and cancer surgery, genetics and hereditary cancer syndromes, and because cancer patients may develop psychological burden or may have psychological troubles, so psychological needs are to be addressed for cancer patients. And in this lecture also you'll be taught how to approach a patient with cancer through some communication skills. The end of the week is always with a themed case discussion on Thursday. Week 2 is about breast diseases. We'll be covering benign breast disorders that will include the differential diagnosis of mastology, nipple discharge, as well as the inflammatory conditions, acute and chronic inflammations of the breast, and the proliferative lesions, some of which will be pre-malignant, so it's an important topic. Breast cancer is discussed in a couple of lectures. The screening programs in the clinical seminars are very important, along with breast imaging modalities. It's an important lecture. You should study it well. Then you'll be having also a lecture on the surgical treatment or options for breast carcinoma. Lastly, at the end of every week, you'll be learning the adjuvant treatment for breast carcinoma or for carcinoma. Adjuvant and neoadjuvant treatments of breast cancer will be the last clinical seminar you'll receive in this course. Week 3 is about GIT carcinoma or gastrointestinal tract. We'll be discussing the stomach first, and then colorectal carcinoma. Don't forget that the last lecture in the colorectal carcinoma is about acute presentation, emergent presentations with obstruction and perforations related to colon cancer or colon and rectal carcinoma. The clinical seminars involves intestinal tumors like GIST, carcinoid lymphoma. They are uncommon, but they are important for differential diagnosis. And as usual, adjuvant treatments of upper, that is stomach, esophagus, and lower colorectal tumors will be discussed by the end of week 3. Week 4 is the second GIT week. It includes hepatopancreaticobiliary carcinoma. Liver cancer is the commonest in Egypt, so there are 2 lectures covering hepatoma or hepatocellular carcinoma. One's for risk factors, pathology, and differential diagnosis of hepatic focal lesions, and the other for surgical and non-surgical treatment options. As for pancreatic tumors of the exocrine and endocrine pancreas to be the next lecture. And lastly, the biliary tract carcinoma or cholangiocarcinoma, as well as differential diagnosis of obstructive jaundice. Clinical seminars for week 4 include a very important lecture about GIT cancer imaging, It includes a collection or a combination of imaging modalities, from plain X-ray of the abdomen to X-ray with dye, up to CT of the abdomen, CTC, which is CT colonography. These tools help us to diagnose GIT carcinoma. And the last lecture, the seminar will be about an uncommon situation, but a complex situation, which is the presence of metastases of unknown origin or cancers of unknown primary. It's an interesting lecture. Week 5 is about head and neck and skin carcinoma. In this week, you will be learning the non-melanoma and melanoma skin carcinoma. The next lecture is a little bit complex. It looks complex, but it's about head and neck squamous cell carcinoma with a stress on lip and tongue carcinoma, diagnosis and management of carcinoma of lips and tongue is very important. A lecture about salivary gland tumors, especially the parotids. And lastly, a reminder about a topic that you have previously had in the previous semester, which is thyroid carcinoma. Actually, the discussion or the lecture will be about solitary thyroid nodule, through which you'll be refreshing your information about management of thyroid carcinoma. Clinical seminars for this week will include differential diagnosis of skin and subcutaneous lesions like dermoid cysts, sebaceous cysts, lipomas, and so on, angiomas, and so on. And as usual, adjuvant treatment therapies for squamous cell carcinoma of head and neck. Head and neck carcinoma spreads regionally to the neck, so neck dissection techniques or lymphatic dissection of the neck is a very important topic. You learn the types of neck dissection, like comprehensive dissection or selective dissection, and the indications, incisions of the neck. It's a good lecture. You'll enjoy it, inshallah. The end of general oncology is by week 6, the chest and uro-oncology. You will be taught by cardiothoracic and neurosurgeons about lung cancer, chest wall and mediastinal tumors, spinal cord and brain tumors. Clinical seminars of this week are rather important topics about palliative management for advanced cancers, pain management for cancers, especially advanced metastatic cancers, a rich topic about emergencies during cancer treatment, and finally, a last clinical seminar about pathological examination of specimens, grossly and microscopically. This will be a collection of pathologies of the cancers that you have studied in the previous 5 weeks. Pediatric oncology weeks follows. Week 7, you'll be learning about pediatric hematology, hematologic diseases of children, including anemia, platelet disorders, clotting disorders. You'll be taught or be given a topic about blood banking, blood transfusions, and a clinical seminar about how to interpret a blood picture. This is very important. In week 8, pediatric oncology, you will learn about lymphomas and leukemias and how to diagnose them. Pediatric oncologic emergencies is a very important topic. You'll also know solid tumors, types of solid tumors in infants and children. An important topic about how to approach a child who presents with lymphadenopathy. And lastly, a clinical seminar about bone marrow aspiration and its techniques. Week 9 follows with uro-oncology. You'll learn in the lectures about urinary bladder tumors, prostate carcinoma, and testicular tumors in males, and renal and suprarenal tumors. Clinical seminars of urology or uro-oncology will include video session for urologic surgery, imaging modalities for upper and lower urinary tract, and the adjuvant treatment of all the cancers that you have had in this week. Gynecology is the final module, the final part of the module. It involves weeks 10 and 11. In week 10, you will learn about cervical cancer, endometrial cancer, and ovarian tumors, benign and malignant tumors, and the malignant ones are divided into primary ovarian cancer and another lecture about secondary ovarian cancer, which is called Krukenberg tumors or carcinoma. Clinical seminar for week 10 includes the following topics: screening for gynecologic cancers, more specifically cervical cancer, a very important topic, rather uncommon but important, about cancers during pregnancy, and as usual, adjuvant treatment for ovarian cancer. And lastly, a clinical seminar. Actually, this is a live lecture, I think, in the museum, in the gynae department, where you learn the pathology of endometrial and cervical carcinoma. In week 11, the final week of your oncology module, you'll learn a lecture. You'll have lectures about germ cell tumors, sex-cold stromal tumors, in addition to vulval and vaginal carcinoma, and lastly, a lecture about gestational trophoblastic tumors. Clinical seminars will include topics about malignant fistula between the vagina and the bladder, vesicovaginal, vagina and rectum, rectovaginal posteriorly. You'll have a lecture about imaging of endometrial and cervical tumors, another one about the genetic basis of gynecologic cancers, and as usual, the adjuvant treatment of endometrial and cervical cancers presented by medical oncologists. A topic about gynecologic cancer statistics, and lastly, last lecture will be the pathology of vulvar cancer and gestational trophoblastic tumors. So that ends the syllabus for oncology semester. We wish you a successful module, and these are my contact details. If you wish to contact me via email or WhatsApp or Telegram, I'll be very pleased to answer. I recommend these resources. You can scan for or download these books or buy them. Okay, they're very important. Yeah, they are considered very important for oncology, especially MD Anderson of oncology. Some sites that could be useful as well, like NCCN and ESMO, where guidelines for American and European cancer societies are published. And thank you for listening. We wish you good luck and always stay safe. Keep calm and help with the fight against cancer. Thank you.